You are welcome to the Neurocognitive examination as part of the Psychiatry Masterclass series. I'm Dr. Prosper Tettey Doe, psychiatrist in the United Kingdom. In this presentation, there will be a case scenario which is clinical, and that will lead to the various approaches to that clinical scenario. So the clinical scenario is a 70-year-old man has been admitted to the medical ward. 3 minutes ago, he had myocardial infarction. Since then, he has been depressed, and 2 days ago, during a lake trip with his wife, he suddenly jumped into the lake, which resulted in head injury. You are required to do a neurocognitive assessment of this patient. A neurocognitive assessment includes assessment of the global cognitive function using tools including the mini mental state examination or MMSE and other low functions, which will go into details. Now, first, the screening, which is the mini mental state examination, has a total score of 30, which is broken down as follows. Orientation, 10 scores, covers the year, season, dates, and day, and month, and the state, and the country, the town, the hospital, or the floor. The second is registration, 3 points, which covers naming 3 objects and 1 second to say each, then ask the patient all 3 after you have said them and give 1 point for each correct answer. Then repeat them until he or she learns all of the 3 and then counts the trials and record. The third category is attention and calculation. It gives 3 points, correction 5 points for serial 7s or word spelling backward. The fourth category is recall, 3 points. As for the 3 objects repeated above. The next is the fifth, which is language. 2 points for pencil, identifying, and watch. And the next is language again, 1 point for repeating the following. No ifs, ands, or buts. Language again, 3 points to follow a 3-stage command. Take a piece of paper in your hand, fold it in half, and put it on the floor. The next is another point for language. Read and obey the following. Close your eyes. Language again is the next category. 1 point for write a sentence on any subject. And the last is 1 point, copy the design shown. Now, frontal lobe, parietal lobe, and temporal lobe. First is the frontal lobe testing. Very important. Test language first. Test for comprehension. Do a single and 2 and then 3-stage command. Ability to understand verbal communication and check for reading. Next, repetition. And next is expression as per comprehension and check for writing. The next is components, which area there's a deficit. Is it dorsolateral, which is cognitive inflexibility? Is it medial, which is apathy or abulia? Or is it orbitomedial, that is disinhibition? There are some signs also of frontal lobe testing. Grasp, palmar mentalis, gait, check olfactory, taste and smell, check Foster-Kennedy syndrome, which is ipsilateral optic atrophy and contralateral papilledema. Cognitive testing for dorsolateral frontal lobe consists of perseveration, abstract thinking, ability to solve things, and attention. In perseveration, one can do first the fixed palm side, or two, copy alternating diagrams example which will be given, and three is the go-no-go paradigm. Abstract thinking can be proverb or similarities and differences. Example, what's the difference between a cow and a horse, or what is common between the two. The next is ability to solve things, which includes verbal fluency. Example, spontaneous word generation. Example, more than 17 words starting with S in 1 minute and more than 13 for F. Planning. Example, what would you do in fire? Is it found if you found a wallet, etc. Then attention is the next, which one can do a digispan, that's forward and backwards, or continuous performance test, that's tap A and follow coins. The next lobe is the parietal lobe. There are a few terms here. Acalculia, ACALCULIA, asks the patient to perform simple calculations with a pen and paper. Example, serial sevens, to take 7 from 100, then 7 from the answer, and so forth. Agraphia is asked the patient to write. Inability is called agraphia. Alexia asks the patient to read. Inability is called alexia. Lesions in the angular gyrus of the inferior parietal lobe can cause these inabilities. Anosognosia, which is lack of awareness of disease, particularly of hemiplegia. Asomatognosia, the patient is unable to recognize part of his or her own body. Astereognosia is inability to identify objects by palpation, and tests can be letting the patient hold an object in the hand, example a paper clip or coin, without showing it to him or her and asking the patient to identify it or to discriminate between different textures by touch. The next is conductive aphasia, which the patient's performance on naming objects and repeating statements is poor, but their speech is usually fluent and comprehension is intact, therefore can follow verbal or written commands. These patients also have impaired reading and writing. The pathway between the Wernicke and the Broca's area is affected in conductive aphasia. Conduction aphasia asks the patient to write to a dictation and to repeat words or phrases, and the patient does poorly. It does better when confronted with objects to name and when writing spontaneous message. Constructional apraxia, inability to draw shapes or to construct figures, patterns, or to copy designs such as interlocking pentagons. Dressing apraxia, inability to dress, tested by taking the patient's pajama top or cardigan, turning it inside out, and asking him or her to put it back on. Finger agnosia, ask the patient to name his or her fingers and or examiner's fingers. Inability to do so is called finger agnosia. Geographic agnosia, ask the patient to locate cities on a map. Idiomotor apraxia, ask the patient to do things such as salute, hammer a nail, kick something, whistle, brush teeth, etc. L to R confusion. Test for left to right confusion is to ask the patient to show his or her right and then left hand. If this is correctly performed, then further ask the patient to touch his or her left ear with the right hand and vice versa. Inability to do this is called left to right disorientation if the right hand is affected. Sensory extinction test. When one side is tested at a time, sensation is normal, but when both sides are tested simultaneously, the sensation is appreciated only on the normal side. The lesion is contralateral to the side with sensory extinction. Spatial neglect mainly occurs with patients having lesion in the non-dominant parietal lobe. Also occurs with dominant lesions, but is less common. This is tested by asking the patient to fill in the numbers on an empty clock face or to draw a bicycle. Presented with a pair of gloves, the patient may forget to put on the one on the neglected side. Visual tests. Note, the optic tracts run through the parietal lobes to get to the occipital lobes. Parietal lobe lesion would give lower quadrant homonymous hemianopia. Temporal lobe lesion will give upper quadrant homonymous hemianopia. Occipital lobe lesion will give homonymous hemianopia. Now, there are some syndromes which I'd like to mention here. Angular gyrus. If the dominant side patient can copy writing but not write them from dictation. There is poor spelling, naming still usually possible, and word blindness, so unable to read out loud or to follow written commands. Jesman's syndrome. Dominant inferior parietal lobe dysfunction, specifically involving the angular gyrus. The patient presents with acalculia, left to right confusion, agraphia, and finger agnosia. Now, we're moving on to the temporal lobe, which will be the final lobe. I hope you are following. The temporal lobe testing, language function. 1. Word repetition. 2. Sentence repetition. 3. Ability to say antonyms for words. Visual recognition includes the following. 1. Identify objects, at least 12 objects. 2. Identify faces. Prosopagnosis. Auditory recognition involves the following. Ability to recognize tunes. Semantic memory, there are 5 parts here. Ability to describe the features of objects, example, color, use, and other details. 2. Semantic knowledge about famous people. 3. Ability to recall names of famous people when cues are given. 4. Ability to describe landmarks like London Tower, etc. 5. Ability to recognize landmarks when cues are given. Memory is the next. That's learn and recall abstract words. How the patient learns and recalls abstract words. The next is visual function in two ways. One is to test for visual field, and two is color vision. To do complete neurocognitive assessment, structure the test so that there is no repetition of testing the same function. Distribute the test to include all the lobar functions. If the initial history favors towards one particular lobar function, then it will be appropriate to do a detailed assessment of that lobe with screening for other lobar functions. Thank you very much for your attention, and I wish you all the best in your career. That's the end of our presentation, and I hope if you enjoy it, subscribe. Click on the subscribe button and you receive future similar presentations. Thank you.